Hi, everyone. Good morning, good afternoon, good evening, and welcome. Thank you so much for joining us today for this webinar as a side event for the C20. This webinar will focus on strengthening UHC engagement, a new Health for All advocacy toolkit for civil society. Before diving in, just a quick note that this webinar is being recorded and that the recording will be uploaded on the Civil 20 YouTube channel at the end of the summit. This webinar also has simultaneous French and Spanish interpretation. For any technical issues or questions, C20 technical staff will be available throughout the event, and you can ask questions by clicking on the chat box. Once again, welcome everybody. My name is Aisling Thorough. I am the interim coordinator for the Civil Society Engagement Mechanism for UHC 2030. It is a pleasure to be here today and to kick off this event in which we will be discussing the recently launched Health for All Advocacy Toolkit to strengthen capacity, inspire action, and mobilize civil society in support of the global movement for universal health coverage. Over the next hour, we will discuss civil society advocacy for UHC and its impact, the background of the Health for All Advocacy Toolkit, how it can be used, and the needs it addresses. During this hour, we will begin with some scene-setting opening remarks. Then we will move to an introduction of the toolkit, and then we will spend the rest of the time on a moderated panel and Q&A discussion. For the scene setting, I would like to welcome Dr. Justin Kunin, co-chair of the UHC 2030 Steering Committee. Justin is also co-chair of the WHO-hosted Social Participation Technical Network, co-chair of the SDG 3 Global Action Plan Civil Society Advisory Group, and civil society representative to the Access to COVID Tools Accelerator and Health Data Collaborative Stakeholder Representative Group. He is president of ACON, Australia's largest civil society organization working on HIV prevention, care and support, and the health of people of diverse sexualities and genders. Welcome, Dr. Justin Kunin.
Thanks very much, Aisling. It's great to see everyone here. And at the outset, can I say what a joy it is to be at this second launch, really. The creation of a toolkit which will give civil society and other advocates the information and the resources they need to drive actionable change on UHC at the country level has been a long-held goal, and here we are. So congratulations to CSEM and the many partners who make this happen. Our strength as a movement really lies in our ability to join forces, and that's on full display today, so well done. And I also want to thank the C20 for continually championing the UHC cause and for your excellent advocacy, particularly over the time of this pandemic through the Global Health Working Group, including around the high-level panel on financing the global commons for pandemic preparedness and response, and also in other places. Your advocacy is so needed, so thank you. So let's begin at the beginning. What is UHC? Well, universal health coverage is based on the human right to health. It's the aspiration that all people can obtain the health services they need of good quality without suffering financial hardship when paying for them. It includes the full range of essential health services, from health promotion to prevention, treatment, rehabilitation, palliative care, and mental health services. It involves increasing access to comprehensive and quality health services as a key component of achieving health for all, and also links closely to broader efforts to make progress on social determinants of health, such as water and sanitation, education, migration policies, workplace safety, and many others. UHC holds great potential to advance progress both on specific health issues and on broader sustainable development goals. For example, UHC reforms have been a powerful driver for improving access to women's health services and expanding the reach of HIV testing and treatment. In the context of the world we currently find ourselves in, There can be no true pandemic preparedness without UHC. Indeed, we should see pandemic preparedness as the step zero of UHC. And at the center of all of these efforts are people and their communities, because without them, health systems lack the eyes, the ears, the hearts, and the hands they truly need to reach the most vulnerable. And there have been bold commitments at a global level. In 2019, UN member states signed a political declaration on UHC at the UN high-level meeting. And through that declaration, governments recommitted to achieving UHC by 2030 and reaffirmed the right to health for all. But how do we get there? Yes, we need sufficient public financing for health to reach UHC, but that's not the whole story. The key asks from the UHC movement are core requests for governments and political leaders to take action on UHC, developed in the lead up to the UHC high-level meeting by UHC 2030, with collaborative input from a range of health and other stakeholders worldwide, including parliamentarians, civil society, the private sector, agencies, networks, and academia. They include asks to ensure political leadership across sectors beyond health, to pursue equity, to create a strong regulatory and legal environment, to build quality health systems, sustain public financing, to engage the whole of society in partnership, to emphasize gender equality, and to promote strong systems for emergency preparedness. There's a lot in there. But the challenge in all of these processes is to make them relevant at the country level. And that's where civil society and this toolkit come to the fore. Civil society, as all of us on this call know, is a vital bridge between decision makers and the end users of a health system. We're often the best place to understand and amplify the needs of communities, especially those who are marginalized and often left out of decision-making fora. So to the toolkit. The Health for Advocacy Toolkit has been, Health for All Advocacy Toolkit has been developed specifically to build capacity, to do all of those things, and to inspire and mobilize civil society in support of the global movement for UHC. It was created to unite advocates across sectors in this common agenda for health and well-being. We're certainly going to need to raise all of our collective voices very loudly within and beyond health system walls to reflect the realities of people and communities and to drive the change, which is our goal and our right. And so a very warm welcome under the UHC umbrella from all of us at UHC 2030. Congratulations on this toolkit. Aisling, back to you.
Thank you so much, Justin. Next, Masaki and Abba will provide an introduction to the toolkit. Masaki is the Program Director for Global Health at the Africa-Japan Forum. He leads advocacy around diverse thematic issues such as AIDS, TB, malaria, and of course, UHC, as part of the Japanese civil society movement for global health. And in 2019, he served as the Japan coordinator for the C20 Global Health Working Group. Welcome, Masaki. Over to you.
Okay, thank you very much, Aisling. And thank you very much for everyone who attended the C20 side event launching the Health for All Advocacy Toolkit. Today, I'm pleased to introduce the new toolkit named Health for All Advocacy Toolkit. I will share the my slide. Can you see me? Can you see it? Okay. First, please wait for a moment. Yeah. Okay. First, I would like to talk about the reason why the toolkit was created. The idea for this advocacy toolkit came in the lead up to the United Nations high-level meeting on universal health coverage, or UHC in 2019. In the lead up to this high-level meeting, the CSEM hosted various country advocacy meetings with civil society and other stakeholders to discuss UHC gaps in the country. Many of these civil society and community representatives asked for more knowledge and information about UHC and about the global ecosystem around the universal health coverage. We then surveyed CSEM members to understand the kinds of the resources that would be most useful in supporting their work on UHC and used those results to shape this toolkit. The Health for All toolkit was developed to respond to these needs and to provide a one-stop shop for key information and to advocate for UHC, hold policymakers accountable for their commitments, and build a broad social movement with civil society to support Health for All. Then secondly, what is the toolkit? The Health for All Advocacy Toolkit provides national level civil society organizations and health networks with the necessary resources to kickstart advocacy initiatives on UHC. This toolkit introduces primary UHC concept and describes some of the many roles civil society plays, not only in the local and national context, but also in global health governance to ensure no one is left behind. This is broad agenda and one that requires the combined advocacy and engagement from a range of stakeholders across sectors. Progress on the road to health for all also advances other sustainable development goals and specific health agendas. Civil society and communities have an important stake in all of them. There are 3 parts in this toolkit. Part 1 is an introduction to universal health coverage, including how it works, why it is needed, key concept, actors, and milestones. Part 2 dives into why it's important for civil society to be part of this global health advocacy. This section explores the critical role of civil society and communities in UHC design and implementation. It conveys the key advocacy messages that you can add to your campaigns. Part 3 provides step-by-step guidance on how to advocate for UHC. By following each step, you will be able to create an advocacy action plan and a company's budget to submit to funders. This section includes helpful templates, such as an advocacy plan template, a budget template, and monitoring and evaluation template. The toolkit also has a list of key resources, advocacy guides, and tools that users can access for more information and support along the way. And finally, how to use. The toolkit is a living document available on www.csemonline.net in English, French, and Spanish. We hope to add more languages as we continue to distribute the toolkit. It will also be updated periodically to include new case studies, information, and resources. We encourage you to share it with your organization and community networks, integrate messages as you develop your advocacy plans, and use the toolkit to bring new advocates to the UHC agenda. We also value your feedback and encourage you to use the toolkit feedback form to share your experiences with the toolkit or provide ideas for further improvement. We look forward to hearing your stories. Thank you very much.
Thank you very much, Masaki, for that excellent introduction and overview of the toolkit. And yes, just to reiterate that it is now live on cscemonline.net and in French, Spanish, and PDF versions. And we really do look forward to continued engagement with civil society all around the world on its use, and that we will continue updating it and incorporating feedback and case studies. So this is just the beginning. Thank you so much, Masaki, for that really wonderful overview. I will now turn it over to Eliana Monteforte to lead a moderated panel discussion and Q&A session. Eliana is the Director of Special Projects at Global Health Council and a CSEM advisory group member. In this role, she leads projects and partnerships to ensure minority voices are systematically heard and included in U.S. global health policy. Prior to joining Global Health Council, Eliana worked at Management Sciences for Health for over a decade and was the coordinator for the CSEM Secretariat. Over to you, Eliana. Thank you.
Thank you so much, Aisling. So I'm very excited to introduce our panelists. We have 4 of them, and they represent different areas of the civil society space, from the local to the national to the regional levels, and they're here to talk to us about how important it is for civil society to advocate for UHC and how tools like the Health for All Toolkit are extremely valuable to the advocacy that civil society organizations and communities do on the ground. So without further ado, I will introduce our first speaker, Natia Loladze, who is the president of the Georgia Red Cross Society and a member of the governing board of the International Federation of the Red Cross and Red Crescent Society. She's an economist and has been leading the National Society for nearly a decade. So Natia, welcome. My question to you is, IFRC is the world's largest humanitarian organization, and as the president of a national society, you're on the forefront of humanitarian emergencies. So can you highlight the role of the national societies in addressing UHC and the priorities you see for civil society and communities? Over to you.
Thank you, Eliana. Good afternoon, everyone. Since its creation, the Red Cross, Red Crescent has been guided by a clear set of humanitarian principles and values that aims in one way or another to effectively contribute to building resilience. We strive to meet people's basic needs for health, shelter, education, food, water, and security. Make every effort to ensure that costs and benefits are fairly shared by all and inequities are eliminated, that human rights, human dignity, and local values are understood and respected, and to ensure that non-renewable resources, biodiversity, and the environment are managed responsibly. IFRC response goes beyond the provision of immediate relief to assist those who have suffered the full impact of the disaster. We also support communities to rebuild their homes, lives, and services, and to strengthen their capacity to cope with future challenges. Due to its auxiliary role to the public authorities and its presence in the communities, the Red Crescent is in a unique position to play an advocacy and advisory role on resilience and accessing health to all. The Red Cross, Red Crescent can transmit the needs and aspirations of the communities on policy, social protection systems, infrastructure, laws, and governance issues needed to create an adequate environment for resilience at national level. The Red Cross, Red Crescent, as you might know, is present in more than 192 countries with a net of community-based health workers and volunteers. When disasters or conflicts occur, Red Cross and Red Crescent volunteers are often able to operate in contexts where other actors can have difficulties. They are well placed to support communities to meet the needs they face, whatever the needs may be. In the past years, the IFRC has taken a prominent role in the process leading up to the UN General Assembly high-level meetings on universal health coverage. So there were several reasons for us. First of all, we saw that there is a real humanitarian need. We strongly believe that our national societies and community health volunteers are an essential means of achieving universal health coverage. We believe that the momentum towards universal health coverage provide an ideal platform for our national societies to engage with their health ministries and strengthen their health services. The Health for All Advocacy Toolkit is going to provide Red Cross, Red Crescent National Society with an extremely useful tool to further achieve their commitments towards local communities and populations. During the country consultation meetings guided by the Georgia Red Cross Society in Georgia, participants in one voice highlighted the importance of universal health coverage with the following statement. It is the time to review the national healthcare system based on public interest and find the pathways to achieve the universal health coverage, leaving no one, especially people under vulnerability, behind. So the IFRC and its members, Red Cross and Red Crescent national societies, including Georgia Red Cross, remain committed to continuing to work towards achieving sustainable development goals, including universal health coverage, and are ready to contribute based on the principles of public health, development, and rights. Thank you.
Thank you, Nadia. It's really wonderful to hear about the great work that the Red Cross and Red Crescent Society does, especially to elevate voices of civil society and ensure that the needs of civil society are being considered when policymakers are developing, right now, COVID-19 response, but just in general health policy. I understand that you have to leave us early, so I take the time to say thank you for being here. And for the audience, just know that we do have other representatives from the Red Cross, Red Crescent societies that can answer any questions that you might have. So still feel free to write any questions in the chat to Nadia and her team. Thank you.
Thank you very much. Thank you. Goodbye.
Great. Bye. So our next speaker is Samuel Matsipure. He is a human rights activist from Zimbabwe. He currently serves as the program manager of GALS, an association that protects, promotes, and represents the rights and freedom of LGBTI people in the country. So Samuel, my question to you, you have extensive experience working with communities on developing programs with a legal and medical framework. Why is it important for marginalized communities to engage with and influence the UHC agenda? And in your opinion, are these communities well equipped for advocacy and accountability around UHC? Over to you, Samuel.
Thank you very much. Well, universal health coverage is important for marginalized communities. As we look in the history of global health efforts, this holds a promise of reframing the global health agenda as it encompasses health for all and the principle for the right to health, which is enshrined in constitutions across the globe, but it is also bolstered by sustainable development goals in which the universal health is firmly located. Universal health coverage gives governments and communities an opportunity to address inequalities, access to quality, available and accessible health services, but also put financial mechanisms that are able to protect communities from accessing healthcare. It is therefore important that we do not leave anyone behind in this initiative, as agreed by member states across the globe. As the countries roll out universal health coverage frameworks and plans, it is important not to leave out those who are criminalized, marginalized, and suffering from human rights violations based on their gender and sexual identity. There are many lessons that we have learned from HIV response in the past decade that we can adapt to UHC approach. When governments and decision makers meaningfully involve communities and place them at the center of HIV response and other epidemics, they get better health outcomes. This has been proven through evidence in the HIV testing and treatment and support for people living with HIV. Universal health coverage, it is a beautiful concept. However, when we still have laws and policies that apply to some populations, how will these groups access services without stigma and discrimination and not suffer from out-of-pocket payments and have tailor-made health services that are responsive to their needs? These populations include gay, lesbians, bisexual, intersex persons, people who use drugs, men who have sex with men, people living with a disability, who are most vulnerable and affected by HIV and other health determinants. There's been demonstrations across the world, some of these groups, when they are left behind, especially in the provision of health insurance and access to essential health services and reduced cost of care due to criminalization. It is therefore important that all member states, governments, civil society, and communities fulfill the commitments by leaving no one behind, especially in sustainable development goals implementation, the universal health coverage process that has to be practical, reforming and ending laws that criminalizes this group as they enforce exclusionary practices and promote hate. It is important that good governance structures for universal health promises meaningful participations for all citizens. Create platforms that are inclusive, especially for criminalized and marginalized groups. Therefore, therefore, universal health coverage has to sit within the human rights framework. This can improve health and well-being of all citizens, include marginalized and criminalized populations. Well, are these communities equipped? Well, while these groups may be making progress in advocating and implementing HIV and sexual and reproductive health services, the majority have been left behind or left out in the UHC processes, especially in places where government is leading the process. And while in other situations, they've been totally left out in social health insurance, health financing plans, and development of strategies that works for them. In most instances, they do not have an idea of what universal health coverage is and what is their role. And this toolkit will go a long way in covering this gap and help marginalized communities to empower themselves, to participate, to contribute, and to hold governments accountable. To ensure that the toolkit being launched today fulfills that intent, it is important, and I'm calling upon funding partners to come on board and support UHC community-supported initiatives. Thank you.
Thank you so much, Samuel. I think you touched on some very important points. Universal health coverage, by definition, or one of the important parts of the definition of universal health coverage, is that everyone has access to quality healthcare services without, being having burden of high costs or, being an economic detriment. So how can you, achieve that if you have policies that are criminalizing or that are violating people's human rights? So important to address those issues to ensure that we reach the everyone in the definition of universal health coverage. So great points. Thank you very much. So our next speaker is Jennifer Ho. She is a feminist and a human rights activist who serves as the Deputy Director of UHC, a regional civil society network of community-based and non-governmental organizations on health and social justice in the Asia Pacific. Jennifer has been working in the area of global health and development for the past 20 years. So Jennifer, UHC recently partnered with the CSEM to host focus groups across Asia, where civil society participants discussed progress made toward universal health coverage in their countries. So would you speak to some of the lessons and key issues civil society and community participants brought up with regards to healthcare access and advocacy for UHC? Over to you.
Great. Thank you so much, Elena, for that question. And I would also like to take this opportunity first to thank CSEM and the Secretariat for the support this year to both UHC and our partners' engagement to global progress on UHC. In particular, with the support, we were able to support communities and civil society organizations in Bhutan, Cambodia, India, Laos, Japan, Nepal, Pakistan, Vietnam to organize and to mobilize this year. So in terms of the lessons and key issues civil society and community participants brought up through the country level consultation, I think Samuel alluded to some of it already, but from our region, I think in the interest of time, I've tried to categorize into 4 big themes, and I think they're quite important. So the first one being, again, marginalized and vulnerable populations and communities are still being left behind. Specifically, issues of stigma and discrimination towards marginalized groups is still very prevalent, and it includes groups such as, LGBTQI community and people who use drugs, migrant, the poor population, ethnic minorities, sex workers, and people with mental health conditions. For example, in Bhutan, that despite the recent decriminalization of same-sex relations by the country, the LGBTQI community continue to face severe barriers while accessing health services due to high prevalence of stigma and discrimination. In countries like Japan, experience of discrimination and abuse often plague women and sexual minorities even more. Participants in Japan, it was really interesting that the issue of, and they spoke extensively about the power dynamic, the patronistic power dynamic relationship between healthcare providers and patients, and how it really impacts the quality of services that people receive there, especially women and other vulnerable and marginalized communities. The other aspect to the marginalized population being continuing to left behind, it's, despite UHC supposedly to be universal, there's still a significant gaps in the U being truly universal in terms of population coverage. I found in a quote from a participant in Japan, really touched me, that that the greater the vulnerability of an individual, the greater the time, the cost, the labor, the patient it require for that person to expand to across and to access health and medical care. It just takes so much more, and a lot of that has to do with because of their vulnerabilities. In Pakistan, very similarly, people who do not have national identity card, they couldn't obtain national insurance card. So despite Pakistan having a national health program, these population, they cannot access free health services. And in some geographical areas, comprehensive packages are not available for people like immigrants, coal miners, homeless people. Women requiring sexual and reproductive health services also have huge issues of accessing health services. And that's not just in one country, that's across the region that we hear that, sexual and reproductive health services that women and people of sexual diversity need, that often the programs aren't meeting their needs. And this was shared across Laos and Cambodia as well. The second issue that we found was that while most countries do have policies or framework around UHC, implementation of these policies or program remain to be a challenge. And so while principles of UHC policies are reflected in health sector strategies and program, there are significant gaps, and we hear this from Pakistan, Cambodia, and Japan as well. And another thing that was highlighted significantly was that there's really no monitoring or accountability mechanism in place, especially one that engages civil society and community group on the implementation. But I think that really starts from, from the process of designing a UHC policy to the implementation of policy and related program and the framework. And that's really across all the countries and all the participants that we spoke with. Under that, in our region, because of the trust issue, because of the high out-of-pocket expenses, people often have to pay for health services. There's a huge private sector health services here. And access to healthcare private sectors, while they're not included in the health insurance program, they're also not regulated and they're also not monitored, while acknowledging that they are an important part of our health service system here in the region. Third, there's still a gap in service coverage. Again, it's not universal. There's a lack of continuous care within the system, between services, between locations, making access very difficult. And this an increasing loss to follow up of patient care in many instances. We see this in India, but we also see that service packages are not inclusive and they're not meeting the health needs of vulnerable and marginalized population. Again, in all the countries that we see. Again, sexual reproductive health needs, including the cost of abortion, it's not covered by most public health insurance or other social welfare program. And SRHR needs has really been underestimated due to the historically high sensitivity around women's access to sexual reproductive health rights in our region and in some of the country in our region in particular. The other couple of things that participants highlighted include addiction treatment for people who use drugs and the support that they need. In most countries, they're not covered while recognizing that there's a significant need. And lastly, there's the mental health services, rather actually the lack of and the urgent need for it to be included in health insurance scheme. And the accessibility of quality services was really mentioned in all country consultation. And I think with the COVID situation, access to mental health services, the urgent need and the dismal gap in the lack of access and availability of mental health services in our region has really been highlighted as a result of the pandemic. Lastly, I think the fourth thing that was really highlighted was the urgent need to really increase all national health budget. Again, insufficient health forces, human resources, we see across the region. And governments, despite the lip services, you need to put your money out and to really increase the health budget in order for us to meet the UHC goal. Again, high out-of-pocket expenses and increased health access at private health facility remains high. In country like Cambodia, which, it really confirms a number of things for us, that there's a high level of mistrust of the government health system. But then importantly, it really puts the high out-of-pocket expenditure on healthcare could easily put people and household into poverty. And then we get into this vicious cycle of vulnerable and marginalized communities not being able to really lift themselves out of the vulnerable situation. So let me stop here. I've highlighted 4 issues and I hope those have been really helpful. Thank you.
Yes, Jennifer, very much so. Thank you for sharing this information. I think your quote, which I can't quote it directly, but the gist of it is really got to me too, that it's, the most vulnerable and the poor and more vulnerable that you are, the more energy and resources it's going to take for you to be able to access those health services. So they really, really need that support. And unfortunately, it's those marginalized populations that are mostly being left behind, which is very sad. And, I think the other point you made that I wanted to highlight was, just because we have a policy change or, the government develops a health plan, that's not the end. That in itself is, of course, an advocacy success, but civil society still has to continue its advocacy afterward to make sure that those policies are being implemented and that stigma and discrimination isn't affecting the policies from actually being successful on the ground. So it's almost, our first success, but civil society needs to continue to advocate and to hold governments accountable. So, amidst the other really great points that you made about mental health and how important it is for governments to, increase their investment in health and decrease out-of-pocket spending. I was a part of a lot of these country consultations in other parts of the world, and we heard a lot of the same things. So thank you for highlighting all of that. So moving on to our final panelist, Collins Masinde. He is a trained social worker and a community advocate from Bungoma County, Kenya, where he leads the Youth for Sustainable Development chapter. He recently coordinated a UHC-driven community intervention supporting women and girls with disabilities to advocate for inclusive and equitable healthcare. This intervention has been highlighted as an example in the Health for All Advocacy Toolkit, so please take a look and read some more details about that. In the meantime, Collins, here's my question to you. Based on your experience, and especially this project in partnership with the White Ribbon Alliance Kenya, how do you see communities and civil society champions playing a role in addressing the gaps in UHC implementation on the ground? Over to you. If you are speaking, you may be on mute. Go ahead.
Thank you very much. Thank you very much for this kind of opportunity. First, may I begin by appreciating White Ribbon Alliance organization, more particularly our mentor, Sandra Marania, who is the advocacy person in charge of in White Ribbon Alliance. So in regard to what we've been doing as a youth involving organization in Bungoma County, we've been implementing a project called UHC for Me project since 2020 up to date. And the role of the civil society, like we, the Youth for Sustainable Development, has been, one is to do what we call community mobilizing. And what we were doing in community mobilizing is we were targeting girls and women living with disability in two sub-counties in Bungoma. We were targeting girls from Webuye West, girls from Webuye, from Umola, so that at the end of the day, we need to sit down and at least get to understand their problems. Another thing is, as a civil society organization, we were amplifying the community needs through the local station, through the media platforms, and also we were creating platforms for girls and women with disabilities, whereby they can sit and talk with decision makers and also make what we call informed choices. As an organization, we've been also doing what we call capacity building. We understand that the girls and women living with disabilities in our communities do not have knowledge about their rights in matters health. So we were doing what we call a capacity building with the help of White Ribbon Alliance. And in this kind of regard, what we are looking forward to achieve? We were looking forward to achieve, one, we need to have what we call a clean environment for people living with disabilities in hospitals. And two, we were looking forward to get reduced time wasting in seeking health services. Number three, we're also looking into getting a sign language interpreter in health facilities so that people with disabilities can be able to access health without any challenge. And we were also looking on improving of infrastructures. And this, we mean these infrastructures, we were looking at the beds at the delivery base, and also we're looking into the ramps to facilitate people cannot walk, use these assistive devices to walk very nicely. Now, as we've been doing this kind of project, there's a couple of things that we have learned. One is decision makers, and we talk about decision makers, we are talking about the health management committees, the county management committees, and also the people that we elect into leadership. Decision makers, they just implement what suits them, but they don't consult so that they can implement something that suits the target population. Number two is for you to create change in our local community. It takes long because of the bureaucracies. As we've been doing this, we bring together people living with disabilities, we bring together the leaders, the county, national leaders. But when you want now to see the impact, now decision making, it takes long because they will say, oh, this person is not there. So it will take long for you to get those kind of feedback. Number two, it is what we call poor priorities. Like in hospitals, there is what we call the health facility management committees, but you find that the county health management committees will come in that particular health facility and implement something that is not a priority. Number three, it is what we call, there is lack of unstrengthened health systems. You find that yes, most of organizations, most of the government talk about there's lack of funding in matters health, but when you go down there, you find that a lot of money is being mismanaged. A lot of money is being wasted just because of lack of what we call a good system in matters health. In Bungoma County, we have been doing a couple of activities, and in my own view is for us to achieve UHC for me come 2030, there is a lot we need to do. And number one thing is grassroots empowerment. I mean, grassroots empowerment is investing in grassroots organizations that are able to fast track development in target facilities so that you can make change. Number two is, I think there is this formation of county UHC 2030 alliances. I believe like we've been doing these things, and this is a lesson we are learning, that when you go and approach the government as one person, they won't take you seriously. But if you have an alliance whereby you're going to fight for something as one community targeting one thing, the government will have to listen to you. To sum up my presentation, it is very nice for us to target people living with disabilities, and those are the people that are left behind in decision making, are left behind in seeking health facilities, and they suffer. But thank God for the UHC for Me project, that it is at least bringing change in our communities through partnership with other organizations. Thank you very much.
Thank you so much, Collins. You brought such a great perspective to this discussion. It's so important to understand the needs of different marginalized population groups, and certainly people with disabilities all around the world, particularly during this COVID-19 pandemic, have really suffered in terms of accessing not just services, but just basic information about how to get to health services, about, in this context, about COVID in particular. And it always amazes me how civil society organizations have really stepped in to fill that gap, almost always without support from, their governments, providing those interpretation services that you mentioned on site, and even just being a resource for people with disabilities that just can't access information online or don't know, where they can access information. Just knowing that they have civil society organizations that they can go to, I think is really, really incredible. And, so great that these organizations, then advocate to governments to help them fill that gap and to really step up and not leave these communities behind. And I think that's where this Health for All toolkit is really going to come into play. So I don't see that I have any questions from the audience yet. I do have some for our panelists, however. While I ask these questions, if there is anybody who is participating in this session, they would like to direct a question to a specific speaker, or if you would like to just ask a question to any of the speakers in general, feel free to type it in the Q&A box, and the IT person will relay the question to me. So as we continue with this discussion, please feel free to do so at any time. So I'm actually going to go back over to IFRC to ask a question to Dr. Lasha, who is an IFRC health department expert. So like UBCASO in the Asia Pacific, the IFRC co-hosted consultations with civil society organizations in Eastern Europe and Central Asia on the progress made toward universal health coverage. I'm just interested in hearing, what did participants in the region highlight as a key challenge toward achieving universal health coverage by 2030, especially in this context that we find ourselves in of COVID-19? So Lasha, over to you.
Thank you, Eliana, and thanks for opportunity to share our experience. As you are very well aware, so we did the similar exercises started in 2018 in the same countries and more. So, and then we could see the difference of the engagement in terms of understanding of the UHC, the role communities and civil societies can play specifically at the country and national level. So that was really very significant, because there were many partners that were participated actually 3 times, 2018, 19, and now, so 3 times, some of them. So well, I would not like to repeat what was said, because it's a lots of similarities. So I just really want to highlight a couple of issues. I mean, what pandemic once more brought to our attention, that health is really the community matter. Including pandemic, it starts in the community and it ends in the community. Without community and civil society engagement, there is no way any health problem to end. So that was very clear. So definitely communication, risk communication, community engagement, financing of the human resources, particularly at community level, when we are talking about community health workers and volunteers, It's vital, it's important. So Jennifer brought the issue of the costs and so I would not like to repeat because that was the case. Disability issue was the case. Even we may talk about different type of disabilities, different type of vulnerabilities in different type of the world. I mean, the case, I mean, the issue is absolutely there. So, and what we should not forget, I mean, we have now representatives from HIV community. So the question is that maybe you would agree, has the COVID-19 somehow brought us back from the HIV targets or no? So we have the messages from the big organization that yes. So meaning COVID, because of COVID, we forget some of the issues. We forget some of the previous commitments, and this should not be the case. So, and that was, we were reminded once more by the participants. Thanks a lot. I don't want to take more time.
Thank you, Lasha. And I mean, I'll just add, Global Health Council hosted the session, the consultation in the United States. And we had very similar comments as what you're saying, Lasha, and you know, what Jennifer shared from UPCASO. And I mean, that just shows you, you know, whether you're a high income country, middle income country, low income country, I mean, marginalized people particularly are suffering the same challenges. And, you know, COVID-19 really showed us that no one was spared. And we are really so far from achieving, you know, universal health coverage that's inclusive and equitable. And so, you know, we have this litmus test that's this pandemic, and we know, you know, now it's glaring at us what these issues are. And so, you know, it's time for civil society and communities to really come together and, you know, loudly advocate for governments to actually do something about this. So thank you very much, Lasha. I appreciate it. So Samuel, I'm actually going to address my next question to you. You participated in the Health for All Advocacy Toolkit launch, and I'm just curious to hear from your perspective how you feel that civil society organizations and communities can use this tool on the ground. Over to you.
Well, I think it gives the community an opportunity to co-create and build a movement to demand accountability and for governments to invest, especially local financing.
That's still nice. I have such a lovely holiday sitting in Paris in hotel room on the side.
Lasha, sorry, Samuel, to interrupt. Lasha, can you go on mute, please?
Yeah, today and tomorrow. No.
If the IT person could please mute Lasha. I don't think he realizes he's still on audio. Great, thank you very much. Samuel, sorry about that, go ahead.
No, that's fine. I think it also gives the opportunity for governments to build and start looking at local financing, especially related to health for all. Because currently most of our governments are relying on external funding, and there's been a push by civil society to make sure that local financing becomes a reality. In many different parts of the world, governments do have resources that they can invest in health, but I think it's not prioritized compared to other things. When you look at Africa, a lot of priorities put in the army, and if you look at the global budget for the army and the intervention around peace and so forth, it's huge, it's billions of dollars, but when you look at health, it's still lagging behind. And I think it will help to bring all communities together to hold government accountable to invest more. There have been efforts and examples we have learned through HIV, but I think more needs to be done. And I think it's also important for people to realize that the gains we have made so far for people living with HIV and in the HIV response, we will lose them if we don't understand how to engage in platforms where universal health coverages are happening, because countries are already way ahead in terms of creating different frameworks. But the engagement at civil society level and engagement at community level is still lagging behind. Yet this intervention is supposed to benefit the most marginalized who are not even being educated on how they can benefit from this. and it cannot come to fruition if they continue to be left behind. So this tool is quite critical because it does give us a guide as to at what level can we engage, what are the things that we need to know and say, how are we able to engage our local governments, the municipal, and also at the global level when decisions are being made. How do we also engage? As I said earlier, there are lessons that we have learned from the HIV response when we put communities at the center of response. And I think this is also critical, especially for criminalized communities. We've also seen a backlash, but also a pushback on some of the laws reforms that are able to protect minorities. So this is an opportunity to actually advance those and make sure that no one is being left behind and no one has access to the equality and dignity that they deserve as citizens of the world. Thank you.
Yes. Agree with all those points, Samuel. Thank you. And, you know, from our experiences on the ground at CSEM, we know these communities and civil society organizations are hungry to be part of this UHC Global Health Advocacy Initiative, not just in their countries, but regionally and also, you know, internationally. And so that's really why we created this tool. And we really hope that, you know, we see people use it so that we have, you know, louder and more powerful civil society voices at all those different levels. So we are getting close to our closing, and I do want to hear from Jennifer and Collins. I actually am just going to ask a really simple question, if you can just answer in a minute. But, you know, in closing, what key message do you want to send to civil society about this tool? What do you want them to walk away remembering? And Jennifer, why don't we go ahead and start with you, and we can, if you could just keep it short.
Sure. Now, I think one of the challenges we identified through the consultation in terms of community and civil society engagement in advocacy for UHC, it's that we really need to increase community and civil society knowledge, understanding, and awareness of UHC. And I think that's where this toolkit is going to come in really, really helpful to help us address this gap. Can I just add a couple other points within a minute on advocacy? I think it's really important for us, again, to learn lessons from other successful movements, such as women's movement, HIV, and the LGBTQ movements, in how we mobilize and how we advocate and push for changes. Building alliances across movement and platforms in our region, for example, you know, beyond the health sectors, to start working with, you know, other alliance and such as Farmers and Laborers Alliance, like union, they're quite powerful in our region, and also to seek out political allies as well, and to recognize that changes don't happen overnight, and sometimes it does take years and across generation, and that's why we really need to continue to support and embrace new leadership, especially of young people. And lastly, a call to the government to increase political will and commitment to include communities, and especially the most vulnerable and marginalized community in overseeing UHC, and to ensure community and civil society are part of, you know, the design, the planning, the budgeting, the monitoring, and to hold government accountable for us to achieve our vision of UHC. Over, thanks.
Thank you. Collins, what is your call to civil society and governments? And you're on mute. There you go.
Yeah, my call to civil society and first for civil societies is we need to really be open in terms of now sharing the skills and expertise in matters implementing advocacy kind of projects, because we are seeing a couple of civil societies like are willing to be part of this kind of platform, by unless they can read and understand this kind of rule and utilize it so that we achieve the set goal and objective of this kind of arrangement. So we level the agenda.
Thank you. Perfect.
And the government is at least they need just.
Sorry if I cut you short. Thank you so much. And so now I'm going to hand it over to Karthi. She's from Waukee Health that co-hosts the CSEM and is the communications officer at the CSEM. So Karthi, if you could just very quickly wrap up and close. And thank you to all the panelists.
Thank you so much, Eliana. Thank you all for attending this session on strengthening civil society engagement for universal health coverage. We're grateful to have had this brilliant set of panelists and speakers through our partners. So on behalf of CSEM, I would like to thank the co-organizers, UHC 2030, UPCASO, AIDS Fonds, the Global Network of People Living with HIV, the Georgia Red Cross, the International Federation of Red Cross and Red Crescent Societies, Living Goods, Love Alliance, the Global Health Council, Management Sciences for Health, NCD Alliance, UNAIDS, White Ribbon Alliance Kenya, and Waki Health. Thank you so much for supporting the creation and launch of this new resource for civil society. The Health for All Advocacy Toolkit is now available in English, French, and Spanish on CSEMonline.net. Please share the toolkit widely. You're welcome to submit feedback and responses to the toolkit online. We really envision a live resource that will be updated as new tools and information become available. This is and has been a collective effort of civil society advocates, so we really welcome your feedback. In the coming months, we will host a series of in-depth workshops to increase familiarity with the toolkit content and facilitate networking among advocates. We've also begun the countdown to the International UHC Day on December 12th, an important moment to build on the global momentum for UHC. This year's theme is Leave No One's Health Behind, Invest in Health Systems for All. To learn more and stay updated on these events, please join the CSEM to get on our mailing list. This event recording will be available on the C20 YouTube channel and will be shared again on our website. Thank you so much again for joining, and goodbye.
Hi, everybody. Thank you so much.
Thanks all. Have a great day.
Thank you. Bye-bye.